This is Nicole, and Nicole is just 1 day post-operative.
Yes.
And yesterday she had surgery for a osteochondritis dissecans on the medial femoral condyle, and that had not healed and left a defect about 10 by 12 millimeters. So we did an osteochondral graft, an 8 millimeter osteochondral graft to patch into the defect. And the procedure went well, and we're hopeful that that's all that she's going to need. We also took a carticell biopsy, and she's aware that if the osteochondral transfer doesn't work, then she'd have the carticell procedure. The defect was a rather large defect, so we get the advantage of filling the crater of the defect with the bone from the osteochondral plug. So if the cartilage cap does not work, then we don't have to go back and bone graft the defect. And so, Tim, you were just going over her program, and she can already do a voluntary isometric like we talked about. Go ahead and make a tight muscle, real tight. And why don't you tell her the rules you tell them, Tim, on this?
So with this, there would be a couple things that we would consider as far as her muscle re-education. And part of that would be to work on voluntary quadricep contractions. So we would look at having her contract her left leg, let her look at where she's starting to get the muscle definition, where she's starting to get the teardrop out of her VMO. She would hold that for 10 seconds, and then we would ask her to come over and voluntarily set her right side and try to create then a similar construct so that she can use her left leg, number one, to make a comparison to teach, but then at the same time then we can have her contract simultaneously to get the carryover from left to right. We'll ask her to hold for 10 seconds to repeat 10 repetitions per set. And Dr. Noyes' rule of thumb really is to then have them perform about 1,000 contractions throughout the course of the day. So we're really looking for her to activate that muscle, for her to get that sequence in place.
Now, Tim, I didn't mean to interrupt you, but we know that those isometrics are not generating that much power.
Right.
But the worst thing that we can have is have her come back like in 2 weeks, and she doesn't even have a voluntary isometric contraction. So, and they get pretty good at it. Make it go real tight, real tight, real tight. Come on. And we really get after them to do it. Now, besides isometrics, you're going to have her do leg lifts.
The component with that would be to consider using electrical stimulation with that, so that we can get the benefit then of the passive facilitation of her contraction with the electrical stimulation, and then couple that with her voluntary contraction. And the premise there being, again, the co-contraction would be stronger than her individual contraction. And she would be asked to repeat that then 6 times per day for roughly 15 minutes, and would be a part of her isometric program. The next step then would be to also then include straight leg raises, which then begins to include some core control or proximal control through her hips. And again, depending on location of the lesion, in this case because it is her medial femoral condyle, we'll also want to make sure that we're getting activation out of her hip abductors, her rotators, adductors, and at that point hip extensors, so that we can again develop hip control, so that when we are permitted to begin more of a progressive gait or weight-bearing program, then we've got active muscle control from her proximal stabilizers.
I think one of the things we've said many times is we really like to see our patients the next day. We really want to get them going and get the muscle and get the motion going. We're obviously aware that we have a knee that has inflammation, so we hope we're going to be smart for that first week and allow for healing and allow for the tissues to come down. So you look very good at this point, but we're going to warn you for a week. We really want you at home. We don't want you running around a lot. We want to get that ice. We want to get that elevation. We want you to keep your TED hose on, because your main part of your rehab is going to come next week. And so next week we really want to have a nice dry knee that we can do. And then, Tim, for her osteochondral graft, I've said that it's all right to go ahead with motion, and I've written a prescription, if you will, that motion is fine for it. So it's fine to keep her motion, but in terms of weight bearing, we're going to hold her from weight bearing for 3 weeks. That should be sufficient time to allow her osteochondral plug to heal. And then after that 3 weeks period of time, then you can wean her from crutches by the 4th, 5th, 6th, probably about the 5th to 6th week. But we really want to protect that healing cartilage for a period of 2 months before we really subject it to any type of loads. she's a good patient. She's going to do all of that, right?
Yes.
Okay. Tim, was there anything else that you wanted to add?
Again, in addition to the RAST, again, ice compression elevation, Nicole has a cold therapy unit which would have been delivered to the hospital for that to be incorporated into her post-operative dressing. She'll be using that. In addition, we'll be asking her to use ice underneath in order to get circumferential cold to the joint as well. So in addition to the stocking that Dr. Noyes mentioned and the elevation, we do want that cold application as well. So while we want the muscle to activate, we want that early passive range of motion, we also need to make sure that we're controlling the swelling, because in most cases, if we can control her swelling, we'll also be able to help control her post-operative pain.